now we will move towards the epilepsy and autism. Are they two sides of the same coin? So we start with some common definitions. These three terminology we are commonly using in our day-to-day practice. That is seizure, convulsion, and epilepsy. So are they same or are they different from each other? If they are different from each other, say how they are different from each other. So seizure is transient occurrence of signs and or symptoms resulting from abnormal, excessive or synchronous neuronal activities in the brain. So it includes both signs as well as the symptoms. Whereas convulsion includes symptoms only. So it is a motor manifestation of the seizures. So it is better to use the terminology seizure, which include both signs as well as the symptoms. For simple example, absence seizures, which does not have any motor manifestation, just a staring loop. So that's we call it as an absence seizures. So better to use the terminology seizures, which include both signs as well as symptoms, which include both motor as well as non-motor manifestations. Whereas Nielsen definition of epilepsy is at least two unprovoked seizures occurring more than 24 hours apart. Okay, so ILE, International League Against Epilepsy, in 2017 introduced one more definition of the epilepsy. Even with the first unprovoked seizures, if the chance of recurrence is 60%, then we also call it as an epilepsy. For example, if the 2 years child presented with the first episode of unprovoked seizures, he had a significant neonatal encephalopathy, global developmental delay, having spasticity, focal neurological deficit on examination, EEG is abnormal. So because of all this associated, the chance of recurrence is 60%. So in that case, even with the first unprovoked seizure, we can label it as an epilepsy. So what we are not going to the deep of the ILE definition. For simple, we will keep the Nielsen definition. That is at least two unprovoked seizures occurring 24 hours apart. So for the better understanding, we will see the epilepsy pattern. So prevalence, epilepsy is a frequent comorbidity in the patients with the autism spectrum disorder. And the prevalence was found to be approximately 5 to 38% in autism spectrum disorder. The frequency of epilepsy varies according to the cognitive abilities, motor deficit, and other associated comorbidities. So for the better understanding, we will see the epilepsy pattern in autism spectrum disorder in three groups. The first group, where primary diagnosis is autism. No any other genetic syndrome, no any other neurological condition, no any other perinatal complications. The primary diagnosis is autism. We can say it as a primary autism. Second group, autism associated with the underlying neurological conditions. And it includes cerebral palsy, CNS malformations, and genetic syndromes like Rett syndromes. And third group, which is rare, epileptic encephalopathy with autism. Here, epilepsy is the primary diagnosis. And the epileptic discharges are so frequent that the brain doesn't work well. That will cause the cognitive impairment, developmental delay, or autistic regression. So starting with the first group, that is primary autism, where autism spectrum disorder is the primary diagnosis without any underlying neurological condition, without any underlying genetic disorder. So prevalence of epilepsy in this particular subgroup is approximately 12%. And it has two seizure peaks, one in the infancy and another in the adolescence age group. We already seen that as soon as comorbidity goes on increasing, the prevalence of epilepsy goes on increasing. So in pure autism, where no any underlying genetic disorder or no any perinatal complications here, the prevalence of epilepsy is approximately 12%. As soon as comorbidity goes on increasing, cognitive impairment, global developmental delay, cerebral palsy, genetic syndrome, the prevalence of epilepsy also goes on increasing. Epilepsy pattern in this specific subgroup, there are no specific seizure types. They can be focal, they can be multifocal, or they can be generalized. The good thing about this group, that is pure autism, is they are well controlled with the anti-seizure medications and rarely they are drug resistant. The main issue regarding this primary autism is abnormal EEG. The main issue regarding the primary autism subgroup is the abnormal EEG. In approximately 4% of the general population, even they don't have the epilepsy or the seizures, we can get the abnormal EEG. Similar in this group, 30% of the cases, even they don't have the epilepsy, will have the abnormal EEG. And the EEG pattern is also not specific. It can be generalized, it can be focal, or it can be multifocal. So abnormal EEG does not mean that the patient has the epilepsy. So what we know in primary autism spectrum disorder, approximately 30% will have the abnormal EEG, but the prevalence is only 12%. Many patients have abnormal EEG but will never have the seizures or epilepsy. So what I want to focus is EEG is not recommended as a routine baseline evaluation if the patient does not have the seizures in primary autism group. Sometimes in autistic children we get some funny movements. They like to see with the corners of the eyes. They have some sensory issues. Sometimes they become the silent because of some sensory stimulations like a red color light or some flickering light. So how to differentiate from the silent seizures? So tell them to make the home videos. Now everybody has the Android phone with them. So tell them to make a home videos. Try to touch the child during these funny moments. If they responded, then it is not a seizure. But if they are still not responding, then it can be the seizure. If the still concern remains, the video EEG should be done and not the routine EEG. So normal EEG does not include the diagnosis. We get on the report that they're lying. Normal EEG does not include the diagnosis. Abnormal EEG does not mean it is epilepsy. Then what is the role of EEG? So EEG helps to characterize the seizure type. Suppose if you got generalized 3 heart spike and wave discharges on the EEG, so it can be the absence seizures and the drug of choice is the ethosuximide. Now it is easily available in the India. If we get hips arrhythmia, typical hips arrhythmia on the EEG, then we can say it can be epileptic spasm, it can be West syndrome, and the drug of choice are the steroids. Similarly, if we got the focal discharges on the EEG, so we can choose the medicines like oxcarbamazepine and carbamazepine for the focal epilepsy. So EEG helps to characterize the seizure type and to choose the medications according to the seizure types. Now we are moving to the second part, that is autism spectrum disorder associated with the underlying neurological disorder or underlying neurological conditions. And this includes genetic syndromes, CNS malformation, stroke, meningitis, and hypoxic ischemic encephalopathy. So we will illustrate this group with some common conditions or some common neurological disorders that we see in common our day-to-day practice that are associated with the autism spectrum disorder. So he is a 3-year-old female child, born of non-consanguineous marriage, normal birth history, normal till the 1.5 years of the life. After 12 months, she has social and language regression with loss of purposeful hand movements. Epilepsy started later at the 2 years of the age, and on examination, it is clearly seen in the video. She has some hand wringing movements. She has some hand wringing movement, loss of purposeful hand movements. I know all have guessed the diagnosis. What is it? So it is Rett syndrome. Very classical female child, normal till the 12 months of the life, social and language regression, typical hand movements, hand wringing movements. So it is a Rett syndrome. So this was confirmed with the genetic testing. We provided in the history that is here, female has the acoustic regression, stereotypic movement, acquired microcephaly, suspected case of Rett syndrome, and that is confirmed with the MECP2 mutations that is consistent with the diagnosis of Rett syndrome. So what I want to convey that any female child with acoustic regression, having stereotypic movements, hand wringing movements, loss of purposeful hand movements, the first diagnosis we should think of Rett syndrome. Similarly, in male child, any male child which is having the acoustic features with some dysmorphic features, the first diagnosis we should think of Fragile X syndrome. Genetic condition, if you want to think, syndrome if you want to think, look for the Fragile X syndrome. Second case, 2.5-year-old male child, again one of non-consanguineous marriage, birth history is normal. Even if the birth history is normal, he is having the seizures from the 4 months of the life. Initially, it's an epileptic spasm. Later on, the terminology was changed like absence seizures, focal seizures with intact awareness. And there is global developmental delay, but there is predominantly delayed language and social milestones with restricted repetitive behaviors, what we call in other words as an autism. So, birth history is normal, till the child having refractory epilepsy, global developmental delay, autistic features, you are not getting the diagnosis. So at 2.5 years when he come to the OPD, we totally undress the child and we can count this kind of hypomelanetic patches on the back. There are also ash-like macules on the patch. So we know what is the diagnosis. Yes, so we did the MRI. MRI was showing the cortical tumors. They are also showing the subependymal hematomas. So the diagnosis is tuberous sclerosis, another common neurological condition that is associated with the autism spectrum disorders. So the what I convey, the any child with the normal birth history but having epileptic spasms, you are not suspecting neonatal encephalopathy, West syndrome, look for the neurocutaneous marker, look for the tuberous sclerosis. Third, the picture is only the diagnostic. It is a spot diagnosis. 4-year-old male child, born of third degree consanguineous marriage, normal birth history. Autism diagnosed at the age of 2.5 years, and epilepsy started late after the 3 years of age. Very classical features: fair complexion, hypopigmented hairs, autostic features, and microcephaly with the consanguinate history. The outside adult neurophysician ordered him the MRI. We can do the MRI, but what will be the next investigation? Fair complexion, hypopigmented hairs, autostic features. So we ordered the TMS. We given the proper history. There is a history of global developmental delay, autostic features, and we are suspecting in the phenylketonuria. And phenylalanine level was approximately 1000 microgram. So it is a treatable condition. So we have to diagnose it early and we have to treat it early so that it has a treatable conditions. We have chosen this is the phenylketonuria. We have chosen these 3 cases in this subgroup, that is underlying neurological conditions. What common things you found in all these groups? Almost nothing. Rett syndrome, initially autism diagnosed, later on the seizures. Seizure types are predominantly absent seizures, weight control. Second, tuberous sclerosis, initially seizures started, autism diagnosed in the latter, different type of immunology, drug resistant epilepsy. And phenylketonuria, autism detected initially, epilepsy started later, and it is a treatable condition. So this group has very wide spectrum. Some are very good responding to the anti-seizure medication, some are drug resistant. So the type and the severity of the epilepsy in this subgroup depends on the underlying neurological condition. If it's a Rett syndrome, it will be well controlled with the anti-seizure medication. If it's a tuberous sclerosis, then probably the epilepsy may be the drug resistant. Finally, we are moving to the last subgroup, that is epileptic encephalopathy associated with the autism spectrum disorder. So what do you mean by epileptic encephalopathy? The conditions in which epileptic discharges contribute to the severe cognitive and the behavioral impairments. That is, epileptic discharges are so frequent that brain doesn't work well. What we call in simple language, if the epilepsy contributes to the cognitive impairment or regression of the milestones, we can call it as an epileptic encephalopathy. And what are the common epileptic encephalopathy we see in our day-to-day practice commonly in the India is West syndrome, which can later evolve into the Lennox-Gastaut syndrome. Dravet syndrome, the child is having the febrile status epilepticus before the 6 months of the life, especially after the first vaccine. After that, he is having frequent febrile seizures at the interval of 15 days, 1 month. After 1 year, the seizures may be a febrile, and after the 2 years, because of the frequent seizures, there is a cognitive decline. So that is typical history for the Dravet syndrome. Epilepsy with myoclonic and atonic seizures, what we also known as the Duth syndrome. So what is the natural history of epileptic encephalopathy? The child meets the required criteria for the developmental milestones. Everything was okay till this. Seizures started. Seizure onset is there, and after that, because of the frequent epileptic discharges, there is a developmental regression. So this is the natural history of epileptic encephalopathy. In this subgroup, epilepsy is the main symptom. This is the common symptoms. Seizures are often drug resistant. And the good thing is, autism symptoms may get little better when the seizures are less frequent. But the vice versa, if they also get the worse when the patient has the many seizures. This entity I want to specially mention here, that is epileptic encephalopathy with spike and wave activation in the sleep. What was formerly known as Landau-Kleffner syndrome, electrographic status epilepticus in the sleep, continuous spike and wave discharges in the sleep, and atypical benign Rolandic epilepsy. Typical benign Rolandic epilepsy will not have the cognitive impairment, but atypical benign Rolandic epilepsy is associated with the cognitive impairment. Another similar natural history, asymptomatic period, the child meets the required criteria for the developmental milestones, epilepsy, seizure started. In this subgroup, in the Landau-Kleffner syndrome, sometimes there may not be epilepsy. They present with the acute deterioration in the behavioral disturbance and language regression, what we call it as an autistic regression. So epilepsy may not be the component, but they presented with the behavioral disturbances and language regression, and the EEG shows, especially in the sleep, continuous spike and wave discharges. So here comes, in last slide, we told that if there is no clinical seizures in primary autism, do not do the EEG. But here we are telling they are sometimes present with the autistic regression and do the EEG. So how will you differentiate this primary autism from the Landau-Kleffner syndrome? The first is onset. Landau-Kleffner syndrome usually start after the 3 years of age, whereas primary autism, as already we see, at the age of 18 months or at the 2 years, primary autism is started. Language and cognitive difficulties in the Landau-Kleffner syndrome. They have good social interaction. They want to communicate. That is not seen in the primary autism. No restricted repetitive behavior and no stereotyping. So any child who is presenting after the 3 years of the age with autistic regression, we can do the EEG for looking the continuous spike and wave discharges in the sleep. And this is the awake EEG for one of my patients. We suspected the Landau-Kleffner syndrome. He presented with the sudden behavioral changes, autistic regression. Awake EEG was totally normal, no spike and wave discharges. And as soon as the child goes into the sleep, there are continuous spike and wave discharges. And this is all of the, throughout the EEG, all of the pages are like this in the sleep. So this is continuous spike and wave discharges in the sleep, electrographic status epilepticus in sleep, Landau-Kleffner syndrome. So why I am focusing this entity here? Because this is the only disorder. If the EEG discharges are controlled with the anti-seizure medications, the cognition and language also improves. Initially we told that does not treat the EEG, treat the patient. But here we are telling, even though there are no epilepsy, no seizures, if we treat the EEG discharges, there is a significant improvement in the cognition and language. So summarizing, we see the three groups. First group, that is a primary autism with seizures. They are well controlled with the anti-seizure medication. Second group, associated with the underlying neurological conditions, and they have varied presentations. Epilepsy, seizures may come before the diagnosis of autism spectrum disorder. They may come after the diagnosis of autism spectrum disorders. Usually drug resistant, include Rett syndrome, tuberous sclerosis, CNS malformations, commonly seen in the India is the HIE. And third group is epileptic encephalopathy. Here, seizures are the main component. And because of the frequent spike and wave discharges, the brain does not work well and there is a autistic regression. So take home message is approximately 88% of the cases of the primary autism will not have the seizures. The prevalence of the epilepsy in primary autism is only 12%. In that subgroup, and we are talking about the first subgroup, epilepsy is usually well controlled with the medications. If the autism spectrum disorder is associated with the underlying neurological conditions, then probably it will be the drug-resistant epilepsy like a tuberous sclerosis. Video EEG helps in the diagnosis if you have doubtful silent seizures or if you are not able to judge whether this is the seizure or whether this is not seizures, because we already saw autistic children will prefer to see from the corner of the eyes. They become sometimes silent after the some stimulation. So it is difficult to find out whether it is silent seizures or whether it is not a seizures. And finally, EEG should be done only if the patient has the seizures. We are talking about the first subgroup, that is 30% will have the abnormal EEG, but will not, most of them will not have the seizures or the epilepsy. Thank you.